Normal architecture is also lost and the normal function of the liver is also lost. Now pathogenesis of cirrhosis. Normally liver has got type 1 and type 3 collagen only in its capsule surrounding the central vein and surrounding the portal triad. In cirrhosis, this type 1 and type 3 collagen gets deposited elsewhere other than its normal region. This collagen is deposited by the Ito cell, which is now known as the stellate cell. Normally the Ito cell or the stellate cell are the fat storing cells of the liver. These Ito cells and stellate cell, they gets converted to myofibroblast in cirrhosis. This conversion of the Ito cell to myofibroblast, the stimulus for its conversion is reactive oxygen species, growth factors, cytokinins such as tumor necrosis factor and interleukin 1. This myofibroblast that is produced, it produces transforming growth factor beta, which is responsible for fibrosis. Myofibroblast also produces metalloproteinase. Metalloproteinase are the enzymes such as collagenase and gelatinase, which have got a metal zinc in its structure, so they are known as the metalloproteinase. These metalloproteinase such as collagenase, it destroys the collagen formed, gelatinase is destroyed the gelatin formed, so this result in recovery of even when these enzymes are formed, they destroy the collagen and that results in the recovery of the cell. So even in the late stage of the disease, there can be recovery of the liver cells. Now diffuse liver injury that leads to necrosis can be due to alcohol, virus, drugs, toxins or genetic disorder. This leads to chronic inflammation and healing by fibrosis. There is bridging fibrosis that results in loss of architecture. There is regeneration of the nodules. There is obstruction to the blood flow and the shunt. This obstruction occurs because the regenerating nodule also obstructs and the collagen that has been formed, the type 1 and type 3 collagen that gets deposited around surrounding the sinusoids also results in obstruction of the blood flow. There is portal hypertension, formation of varices. There is liver failure that leads to debilitation, ascites, edema, bleeding, jaundice. There is hormonal imbalance characterized by spider nevi and testicular atrophy. This is a picture showing the normal liver sinusoidal area. The upper portion shows the sinusoids, which is lined by the endothelial cells. This endothelial cell has in between the Kupffer cells are present. The space between the endothelial cell and the hepatocyte is known as the space of Dicey. In this space is the Ito cell or the stellate cell present, and there is fine collagen, which is the type 4 type of collagen present here. This is a fine delicate type of collagen. Now in cirrhosis, what happens? This Kupffer cell, they start to produce certain factors such as which causes proliferation of the Ito cells and conversion of it into myofibroblasts such as platelet derived growth factor, transforming growth factor, MCP. So all these are produced and the Ito cell or the stellate cell gets converted into myofibroblast, and it produces the fibrogenic factor, transforming growth factor beta. And this transforming growth factor beta, when this is produced, then type 1 and 3 type of collagen gets deposited in the space of Dicey. These are thick collagen and they get deposited in the space of Dicey. Cirrhosis can be due to many causes. 60 to 70% chances of cirrhosis is due to alcohol. Alcoholic liver disease causes 60 to 70% cirrhosis. Viral hepatitis can also cause cirrhosis. Biliary disease, primary hemochromatosis, cryptogenic cirrhosis, Wilson's disease, alpha-1 antitrypsin deficiency, cardiac cirrhosis, Indian childhood cirrhosis, cirrhosis in autoimmune disease, non-alcoholic cirrhosis, and miscellaneous cirrhosis. These are the different types of cirrhosis that can occur. Now, cirrhosis can be classified into morphologically into micronodular, macronodular, or mixed. Micronodular when the size of the nodule is less than 3 mm in diameter. Macronodular when the size is more than 3 mm in diameter. And there can be mixed where both micro and macronodular can be seen. Type of cirrhosis, it can be either active cirrhosis or inactive cirrhosis. Micronodular can be active, inactive, macronodular can be active or inactive, or even mixed can be active or inactive. Active form means there is necrosis and inflammation still present in the liver. An inactive form where necrosis and inflammation stage is over. This is a picture showing micronodular cirrhosis. That means the nodules is less than 3 mm in diameter. This is a picture showing macronodular cirrhosis where the nodule is more than 3 mm in diameter. Now we will discuss about the first cause of cirrhosis, that was due to alcohol. We will discuss about alcohol liver disease. This is a picture showing normal alcohol metabolism. Alcohol or ethanol, when it is ingested, it gets converted into acetaldehyde. This conversion of ethanol to acetaldehyde can occur in cytoplasm or cytosol by an enzyme acetaldehydrogenase, and this occurs by an enzyme alcohol dehydrogenase. Here NAD gets converted into NADH. Then ethanol can get converted into acetaldehyde in catalase by an enzyme catalase which is present in peroxisome, or it can get converted into acetaldehyde by P450 which is present in smooth endoplasmic reticulum. So ethanol gets converted into acetaldehyde either in cytosol or in peroxisome or in smooth endoplasmic reticulum. And in conversion of ethanol to acetaldehyde, NADH gets reduced to NADH. NAD gets reduced to NADH. Now acetaldehyde can get converted into acetate. This acetaldehyde converting to acetate occurs in mitochondria by an enzyme acetaldehyrogenase. Here also NAD gets reduced to NADH. Then the acetate form get converted into acetyl-CoA and finally to carbon dioxide and water. So this is the normal metabolism of alcohol. So its byproduct, one of the important byproduct is acetaldehyde, and there is another thing that is occurring in this metabolism. NAD gets converted into NADH. NAD gets reduced to NADH. So this is the normal alcohol metabolism. Now what is the effect of alcohol? There is increased NADH formed. So this increased NADH-NAD ratio results in lactic acidosis, and it also causes accumulation of fat, because in fat metabolism, fat oxidation also NAD is required. In fat oxidation NAD is required, and in fat oxidation NAD gets converted into NADH. But due to the presence of alcohol, NAD gets converted into NADH, so there is less NAD present for fat oxidation, so there is accumulation of fat occurring. Then acetaldehyde that is produced, it causes protein acetaldehyde adducts which damages the cytoskeleton and membrane. It also forms malone dialdehyde adducts that causes production of autoantibodies. There was another metabolism at P450 microsome. This was here also ethanol was getting converted into acetaldehyde. So that results in also formation of reactive oxygen species. And what else occurs? P450 is a place where metabolism of many other drugs, toxins occur. So as alcohol causes saturation of P450, the metabolism of the other products is not able to be done. So that also results in toxic effect of the other products. Now alcohol also releases lipopolysaccharide from the gram-negative bacteria of the intestinal flora. Normal intestine flora also has got many gram-negative bacteria, and alcohol causes release of the lipopolysaccharide from these bacteria. It also results in release of tumor necrosis factor from the Kupffer cell, which results in damage of the liver cell. Alcohol itself also has got direct effect on the liver cell, and it causes damage to the microtubules and mitochondria. So this was the toxic effect of alcohol in our body. Now that these results in alcoholic liver disease. Alcoholic liver disease is characterized in 3 types: alcoholic steatosis, alcoholic hepatitis, and cirrhosis. In alcoholic steatosis, there is only fatty change in the liver. This is the most frequent and earliest change of alcohol in the liver. This is due to the direct toxic effect of the alcohol on the liver. There is increased triglyceride, increased fatty acid, decreased oxidation of fatty acid, decreased formation and release of lipoproteins. Here morphologically we can see, due to the accumulation of fat, microvesicles are formed. These microvesicles, they coalesce together and macrovesicles are formed. Later the hepatocyte bursts and the lipid comes out, and that results in formation of granuloma. This type of granuloma is called lipogranuloma, and then it is surrounded by fibrosis. This is a picture showing fatty liver. This is alcoholic steatosis. The liver appears yellow due to the deposition of fat. This is a histological picture of fatty liver. Here the fat areas are seen as white vacuoles. Prognosis of alcoholic steatosis is that it resolves completely if alcohol is stopped. Now the second thing that occurs in alcoholic liver disease is alcoholic hepatitis. It is also known as steatohepatitis. It is characterized by fatty change in the liver. There is ballooning degeneration. There is focal necrosis. There is inflammatory cell infiltrate. There is Mallory bodies formed. Mallory bodies are also known as alcoholic hyaline bodies. Mallory bodies are the intermediate fragments or the cytokeratin. Cytokeratin gets deposited in the hepatocytes, giving it a eosinophilic appearance, known as Mallory bodies or alcoholic hyaline bodies. There is fibrosis. Fibrosis can be central hyaline sclerosis. It can be perivenular fibrosis around the central vein or pericellular fibrosis around the hepatocytes. Around the hepatocytes, when fibrosis occurs, it gives a web-like appearance or chicken wire appearance or creeping collagenous type of appearance of the fibrosis. Pathogenesis of hepatitis is it can be due to immunological attack, it can be due to free radicals, or it can be due to acetaldehyde. Acetaldehyde causes lipid peroxidation, and acetaldehyde also form adducts which damages the hepatocytes. This is a picture showing Mallory alcoholic hyaline bodies. The dark pink areas are the Mallory hyaline bodies. These are the pre-keratin deposited in the liver cells. Now, clinical features of alcoholic hepatitis, it can be either asymptomatic, or there can be vague abdominal discomfort, or there can be hepatic illness characterized by jaundice, fever, nausea and neutrophilia. In 10 to 20% cases, death can occur. In 1/3 cases, cirrhosis can occur. Now, alcoholic cirrhosis. In 60 to 70% of cases of cirrhosis is due to alcohol. 10 to 15% of all alcoholics develop cirrhosis. Alcohol consumption of 60 to 80 gram per day in male for more than 10 years can lead to cirrhosis, and 20 gram per day in female for more than 10 years can lead to cirrhosis. Female has got less capacity of metabolizing alcohol because female GIT has got less capacity to metabolize it. Alcoholic cirrhosis is characterized by, earlier there is micronodular cirrhosis, later it is followed by macronodular structure. Liver is shrunken, there is nodular architecture is present. Fibrosis that occurs initially is delicate type of fibrosis, later it is replaced by dense fibrosis. The hepatic parenchyma is disorganized, there is necrosis, inflammation and bile duct proliferation seen in alcoholic cirrhosis. This is a picture of alcoholic cirrhosis with fatty change. Alcoholic cirrhosis can be either asymptomatic or it can cause hepatic coma, there can be massive hemorrhage, there can be infection, there can be hepatorenal syndrome, or there can be hepatocellular carcinoma. This is a picture showing how a normal liver can go up to cirrhosis. The first topmost picture is of a normal liver. When there is exposure of alcohol, it can go into steatosis or it can go into hepatitis. If the person abstains from taking alcohol, leaves taking alcohol, then from these both steatosis and hepatitis, it can revert back to normal liver, or a hepatitis can go to steatosis and again back to normal liver. But if he continues to drink alcohol, then the liver will go into cirrhosis. So this is about the alcoholic liver disease. So we have discussed about the different types of alcoholic liver disease: hepatic steatosis, hepatitis and then cirrhosis. Now the changes in chronic alcoholics other than the changes in the liver. We have till now discussed all the changes that occur in the liver. Other than the liver, alcohol also damages other organs, such as in GIT there is bleeding due to gastritis, gastric ulcer, esophageal varices. There is thymine deficiency leading to peripheral neuropathy, Wernicke-Korsakoff syndrome. In the heart there is congestive cardiomyopathy. In moderate dose, alcohol increases HDL and it has got beneficial effect on the heart. It causes acute and chronic pancreatitis. In pregnancy, if alcohol is taken, it leads to fetal alcohol syndrome, which is characterized by microencephalopathy, growth retardation, facial abnormalities. Alcohol also causes cancer, many types of cancer. It can cause oral cancer, esophageal cancer, liver cancer and breast cancer. Alcohol also causes malnutrition. Alcohol gives ready-made energy that is called empty calorie, and therefore other normal calorie is not able to be taken, that leads to malnutrition. Now another type of cirrhosis, other than we have already discussed about alcoholic cirrhosis. Now the second type of cirrhosis, post-necrotic cirrhosis or post-hepatic cirrhosis. This is characterized by either it can be due to virus such as hepatitis B virus and hepatitis C virus, or it can be due to drug, carbon tetrachloride, phosphorus, acetoaminophene, or it can be due to other causes such as brucellosis, clonorchis, Wilson's disease, or it can be idiopathic where the cause is not known. In this type of cirrhosis, liver becomes small, less than 1 kg, and there is macronodular structures, nodules are formed. Microscopically, macronodules are seen, but some part of the liver is not involved. It does not involve the whole liver. There is thick fibrous septa seen. Active necrosis is not seen, but there is mononuclear cell infiltration showing follicles. there is bile ductule proliferation is seen. Hepatocyte shows regeneration having multiple nuclei. The clinical features of chronic hepatitis is seen, which may later develop into hepatocellular carcinoma. Now, hemochromatosis, iron storage disorder. This also leads to cirrhosis. Hemochromatosis can lead to cirrhosis. Hemochromatosis is characterized by micronodular pigment cirrhosis, diabetic mellitus and skin pigmentation. Diabetic mellitus and skin pigmentation are together characterized as bronze diabetes because the skin gives a bronze color appearance, so it is called bronze diabetes. This hemochromatosis is disorder of the iron storage. This disorder can be either genetic or acquired disorder. Genetic, it can be due to disorder in chromosome 6. It is an autosomal recessive disorder. Due to this disorder, there is increased absorption of iron from the intestine. And in acquired disorder, it can be due to iron overload. It can be due to thalassemia and multiple transfusion. Multiple transfusion causes multiple taking in of the iron. So, this leads to hemochromatosis. Now, hemochromatosis picture is given below. Iron is stained by Prussian blue. So, the blue areas are the iron deposition in the hepatocytes. Now, another type of cirrhosis is biliary cirrhosis. This occurs due to cholestasis, that is obstruction to the bile flow. This cholestasis can be either intrahepatic cholestasis or extrahepatic cholestasis. This biliary cirrhosis can be of three types: primary, secondary or primary sclerosing cholangitis. Primary biliary cirrhosis, cause is not known, unknown etiology. It occurs more in female than in male. It can be either familial or it can be due to increased cholesterol level or it can be autoimmune. Gross picture, the gross changes in the liver appears greenish and later it is shrunken. Microscopically, there are 4 stages, stage 1, 2, 3 and 4. In stage 1, there is florid bile duct lesion. In stage 2, there is ductular proliferation. In stage 3, there is fibrosis and scarring, and in stage 4, there is micronodular pattern seen. Secondary biliary cirrhosis, here obstruction occurs due to either gallstone, biliary atresia, cancer of the biliary tree and the head of the pancreas, post-operative stricture. Microscopically, there is bile stasis is seen with bile lakes, cholangitis, that is inflammation of the biliary tract, and micronodular cirrhosis. Then cirrhosis due to primary sclerosing cholangitis. Here the cause is not known. It may be either bacterial, viral or autoimmune cause. There can be both intra and extrahepatic obstruction. There is progressive inflammatory sclerosing and obliterative process. Fibrosis occurred in the biliary duct that leads to the obstruction of the lumen. This is a picture showing the bile lake in biliary cirrhosis. The brownish area are the bile lake among the normal hepatocytes. Now, there can be another type of cirrhosis, that is cardiac cirrhosis. Cardiac cirrhosis is due to right heart failure. When the right heart fails, then the back pressure to the vena cavas. This back pressure leads to enlargement of the liver. There is central vein gets dilated and fibrous strands radiates from this central vein due to the necrosis of the hepatocyte, which are later replaced by the fibrosis. This gives a nutmeg appearance of the liver. Nutmeg is a fruit that has got alternate red and white areas. So, just like that fruit, this liver also shows this type of cirrhosis. So, in central vein gives the red appearance because the central vein is congested, so giving it a red appearance, and surrounding area is necrosed, giving it a yellowish white appearance. Now, Cirrhosis due to Wilson disease. Wilson disease is characterized by hepatolenticular degeneration. It is a autosomal recessive disorder. There is increased copper deposition in the liver, brain and eye that leads to cirrhosis. The cirrhosis of the liver is macronodular type. In the brain, there is bilateral degeneration of the basal ganglia, and in the eye, there is case of Fletcher's ring seen. This ring is a greenish brown pigmented ring in the cornea. Alpha 1 antitrypsin deficiency. This is an autosomal co-dominant disorder of chromosome 14. It is characterized by cirrhosis in liver and emphysema in the lungs. This alpha 1 antitrypsin is produced by the rough endoplasmic reticulum, and alpha 1 antitrypsin is a protease inhibitor. So it inhibits the protease enzyme, and protease enzyme causes destruction of protein. So if this inhibitor is absent, then protease enzyme works uninhibited and it causes destruction of protein that leads to disorder of the liver and lungs. Indian childhood cirrhosis. This occurs in 6 months to 3 years of age, especially in Hindus in India. It is mainly due to the toxic effect of copper. In the Hindu families, Indian Hindu families, copper is used for cooking, for storing food and for storing water. So this may lead to cirrhosis, Indian childhood cirrhosis. Death occurs within 1 year. Miscellaneous. It can be due to metabolic cause such as galactosemia. It can be due to infectious disease such as brucellosis. It can be due to GIT disease such as inflammatory bowel disease, or it can be due to infiltrative cause such as sarcoidosis. Cryptogenic cirrhosis. When the cirrhosis of the liver does not fall into any of the above categories, then it is said to be of cryptogenic cirrhosis. Cryptogenic, the word cryptogenic means hidden. When the cause is not known, it is hidden type, then it is cryptogenic cirrhosis. Now, what are the complications of cirrhosis? Cirrhosis can present as asymptomatic, or it can cause progressive